Hello and welcome everybody. Annie Gibbins here, the CEO of Glaucoma Australia. I am delighted to be chatting tonight with Dr. Nathan Kerr. Thanks for those who have taken the time to listen in. We are going to be talking all things surgery, different surgical interventions in glaucoma, and why surgery might actually sometimes be the best option for you. So I'll tell you a little bit about Dr. Kerr, and then I'm going to just spend the time asking him some questions that have come in over the last few months from different patients around the country. And so a little bit about Dr. Kerr. He's the principal investigator and clinical lead for glaucoma surgical trials at the Centre for Eye Research Australia, their research centre. He's a pioneer of minimally invasive glaucoma surgery, or MIGS as we'll call it, having been the first surgeon in Australia to implant or be trained to perform several types of minimally invasive glaucoma surgery procedures. So he's quite a pioneer. Dr. Kerr's primary research interest is in surgical management of glaucoma, and in particular to determine the safety, clinical efficacy, cost effectiveness and impact on quality of life of newer minimally invasive surgical techniques and implants compared to traditional therapies. So I am going to ask him a whole lot of questions today, and we're going to hear from the expert himself. So thank you so much for joining us, Dr. Kerr.
For inviting me, and a huge shout out to Glaucoma Australia and the entire team for all you do for people and their families who are living with glaucoma. It's great to join you on evenings like this where we can chat about all things glaucoma and answer people's questions that they might have.
Oh, thank you so much. Now, you're an ophthalmologist specializing in glaucoma. Let's just start there. You know, we often get questions going, but aren't all ophthalmologists specialists in glaucoma? And I'd love you to just provide the answer. What's the difference of an ophthalmologist specializing in glaucoma?
Yes, it's a great question, because there are many different professionals who are helping care for people with glaucoma, and we all work together. And we have optometrists, so they are the people we see most commonly. These are highly trained eye professionals. They've done 4 years of university training, and they can diagnose, they can commence treatment, they can improve vision with glasses and contacts, but they don't do laser or surgical procedures. And so they will refer patients to somebody like myself. And so I'm a medically trained, and then I've done further training to become an eye surgeon or specialist. And in my case, I've done further training, 3 years of research and 2 years of clinical training to subspecialize in glaucoma. And so I treat people that of disease from newly diagnosed, where we're confirming the diagnosis, we're looking at the type of glaucoma, what's caused it, how severe is it, and then coming up with a treatment plan to help preserve people's eyesight. People are referred to are not working or causing side effects, to look at whether a minimally invasive procedure can help reduce their need for drops, through to complex surgery where surgery has been performed but either is working or is working too well, and to look at how I can revise their procedure to help give them the best outcome.
Fantastic. Oh my goodness. It's all about the patient outcomes for us. One interesting point there was, so yes, you're a doctor first, then you become an ophthalmologist, then you do further training to be a glaucoma specialist. Should our patients be aware? Is that something that they would ask their ophthalmologist? Are you a glaucoma specialist? Is this a sensitive question to ask them? And are there advantages of them? Obviously, I would assume yes, that they are specializing in glaucoma.
Yes, yeah. Absolutely. So many ophthalmologists are able to diagnose and treat glaucoma, and even not specialists trained in glaucoma know their limitations, and if they feel that a patient treatment that they themselves may not perform on to somebody like myself who can perform type of treatments, whether it be laser types of surgery. And so absolutely, I think it's a great question to ask, and people will not offend. We are all here for the patient's benefit. And likewise, I have patients who come with a condition that might not be, my area of expertise, and I will refer them on. So, for example, somebody wants, their retinal condition treatment, I will refer them to somebody who is best able to manage that condition. And we completely understand that. We're not offended by that question. We want the best patients, and so absolutely ask away.
And I think that's great for patients to know, because that's exactly it. Once you actually specialize, you become so niche. It's kind of like if you see something that's not yours, you're equally happy to go, no, you need to see the expert in that area. So you are basically in your area of specialty, if we're talking surgical interventions, you regularly are seeing the more complicated cases, people who have complex conditions. So how is glaucoma traditionally been treated, or typically treated, compared to where you're working in that modern space, or that pioneering space in surgery?
Yeah, so it's been a really exciting time to be involved in glaucoma management, and we've seen a real shift in the way that we treat glaucoma, because historically glaucoma was treated with medications, usually in the form of glaucoma eye drops, and where one eye drop was not working, to 2, sometimes 3, sometimes 4 different medications, which they needed to use at the right day, sometimes multiple times of the day. And for many years, we had few surgical options. People were on drops and more drops, and then often very late in the disease, often once significant amounts of vision lost, people with their surgery. And that was because the operation that we've had, while it is very good at lowering pressure, and while it has certainly saved the eyesight of people, is a very large operation. It involves a lot of cutting and stitching, and it can have a really slow recovery. Sometimes vision blurred for 6 weeks to 3 months. Sometimes even about 1 in 5 people see vision after that operation. And while that's better than losing eyesight from glaucoma, it's nonetheless very frustrating for people. And some of those can be sight-threatening. And when we look at large clinical studies, we find that about 1 in 3 operation may have a complication, and nearly 80% need some type of manipulation to get the optimum results. And so while it's very good, it's a lot of work. And so that was one very in the disease, because we really had little between medications through to the most invasive operations.
It's certainly an exciting time, isn't it? When you think of, people historically have been in the industry that there wasn't much progress for quite a long time. And then all of a sudden now there are so many treatment options. So it must be very exciting for a doctor like you coming in at a time where those options are already here, and they're also in the pipeline. So super exciting. What are the challenges associated with long-term chronic use of medications that people have been on to treat their glaucoma?
Yeah, no, it's a good question. And there are a number of limitations of daily glaucoma eye drops. The first is side effects. We did a survey of over 2,500 people who had glaucoma who were treated with eye drops, and we about their satisfaction with eye drops. And what we found is that 1 in 2 people reported experiencing some form of complication or side effect from their drops. And that could be such as red, sore, burning, or itchy eyes. And that can be often due to the medication itself, or sometimes the preservatives in the medicine, which are needed to help prevent bacteria to grow. Another big problem is that people can struggle to use their drops consistently every day at the right time of day. Life gets busy. We can be running off to work or picking up the grandchildren, and we can be late with our drops. Sometimes we might miss the drops altogether. And some people have difficulty using eye drops due to problems like arthritis or vision problems or memory problems. And we know from clinical studies that as few as 4 out of 10 people use their drops as prescribed. And that's a real problem. And they can be expensive too. Particularly some of the new preservative-free medications can easily be upwards of $50 or $60 for a month's supply. And drops are not always effective. Even if you do take them religiously as prescribed, people's glaucoma can still continue to get worse. In one large study, about 60% of people, even on drops, still continue to deteriorate. So they're helpful. They can slow the disease down, but they're not always enough by themselves.
It's a surprise for many people listening in. I know we've just been had another Facebook Live recently that's actually sort of implied that too. People who've traditionally thought drops are the stalwart actually might be surprised that many people are using laser and then also the micro stent. So let's have a talk about then the term minimally invasive glaucoma or MIGS. You know, it's becoming more and more common. What is MIGS, if you like, and how often, how does it differ from traditional surgery that most people have got like a bit of a fear factor when they hear the word surgery or trabeculectomy? What are MIGS and how are they different?
Yes, yeah, great question. So MIGS are small, either catheter or stent procedures where we use small micro incisions to help treat and lower eye pressure and reduce or eliminate the need for glaucoma eye drops. And they help sort of expand that difference between glaucoma drops and our most invasive surgery. And so this has led to a real paradigm shift. And so this has enabled us to offer surgery at an earlier stage in disease before people have lost significant amounts of vision, with the goal of helping to better control their glaucoma so that they don't lose vision from glaucoma. Ideally, they can need less medicines or sometimes even no glaucoma medications, because we know of all of those problems that can go with medications, like the side effects and the struggling to remember to use them, and hopefully reduce the need for major invasive surgery. And there have been some very large trials that have looked, and these devices have been shown to be very effective in the treatment of glaucoma. There are many different procedures, and they all come under this sort of MIGS umbrella. But many of the studies have taken people with glaucoma and cataract, and they've looked at people who have just had cataract surgery, and they've compared them to people who have had cataract surgery and a MIGS procedure. And what they've found is that the people who had the MIGS procedure often had better control of their eye pressure. They were on less, often no medications. And depending on the type of MIGS procedure, they were less likely to have to go on to have that major operation that, as you said, people were often afraid to have.
So it's a real good news story, isn't it? And there's a variety of them on the market too. That's something that could confuse patients. Is it just that it's a brand differential, or is it actually that the surgeon, you know, in discussion with the patient, will talk about different MIGS for different, you know, types of issues with the patient from a clinical perspective?
Exactly. So they're not all the same, and there's no one stent or MIGS procedure that is perfect for everyone. And so it's really important that people talk with the surgeon to find that they choose the procedure that is right for them. The types of MIGS can be broadly thought about as two different types. Inside our eye, it's always making this clear watery fluid that brings in nutrients, and then that fluid circulates out through a drainage system. And in glaucoma, that drainage system becomes blocked. It doesn't let the fluid out as well as it should, and that can cause this buildup of pressure. And so one group of MIGS procedures help to restore the eye's natural drainage channels. And so they either make an opening in that drainage channel, such as a stent, like some names are iStent or Hydrus, or they can help clear out the channels with a little catheter, something called iTrack, and so that sort of flushes the drainage system as well as stenting it. And then the other way they vary is in terms of how much of the drainage channel they treat. And so certain ones, like iStent, they will treat two sort of focal areas of the drainage channel to help open it up to let the fluid drain out. The Hydrus is a slightly larger stent. It's about the size of an eyelash. It's very small, you don't see or feel it, and it just sits in the corner of the eye, and it helps dilate and open up about 90 degrees of the drainage channel. The drain is a circle, so 360 degrees is the whole drain. And then there's the eye track. And so this is a little fine microcatheter. It's similar to an angiogram, so where people have, or angioplasty, where people have blockages in their heart. A little catheter is fed to the area of blockage, and then that is dilated to relieve the blockage. A very similar process with the eye track, and so it helps dilate all 360 degrees of the drainage channel to treat the entire drainage system, and not only the initial channel, but it also helps clear out some of the downstream blockages, kind of like clearing out the gutters in the drain pipe, where you flush it with water to clear out all the leaves. And so that's one class. And then the other class is ones that create a new channel. And so we assume the existing drainage channel is blocked. What we want to do is create a new channel for the fluid to drain out. And they connect to the inside of the eye to under the skin of the eye. And those common names will be the Zen or the PreserFlow. And they work in the similar way to trabeculectomy, but in an operation that is much less invasive. And so I guess as a whole, you can think about these procedures, they've got really a number of advantages. They're much less invasive, so there's less cutting or stitching on the eye. And so that's less trauma on the eye, and that gives people a shorter operation, but a much faster recovery. They can be often back doing normal activities very shortly after the procedure. The other big benefit is safety. They have less complications, and that's important, particularly if we're operating on people who have less severe disease. We want the procedure to be safe. We don't want it to have complications that could make them worse. And of course, we want them to be effective. And again, as we talked about, there is strong evidence to support that these procedures are effective at helping reduce eye pressure as well as the need for medications.
Oh. Thank you for explaining that so clearly. For those listening in, I think, yes, you're like me going, oh, that is fascinating. There's so much plumbing and drainage, and it all makes sense if you're wanting to be reducing that pressure that builds up in the eye. When you listen to treatment from this kind of conversation, you'd be thinking, well, why doesn't everyone have, MIGS? Why would you start with drops or laser? Is it that you get to a specific stage in your treatment that it is therefore more suitable? Is there a specific patient type or type of glaucoma that this would be useful for? Sort of what decision making do you engage at the decision to use a MIGS on a patient?
Yep, excellent. Yeah, no, great question. So you're quite right. The way we treat glaucoma has changed. And so previously, where we once have written a prescription for drops and say, take these for the rest of your life, often for newly diagnosed people, we now do a painless laser procedure called selective laser trabeculoplasty, or SLT for short. And we're doing a lot more from a lot of these procedures. And it helps to, again, clear out the drainage channel to help fluid drain out and help lower eye pressure. But the advantages is that, it provides better pressure control over drops alone. It preserves more of the peripheral vision and, again, reduces the need for further invasive surgery. But the problem with SLT is that while it is effective for many, there are some people who don't respond to SLT, and there are people where they initially respond, but the effect can be short-lived and it can wear off over time. And so people need further treatment to help control their glaucoma. And so we tend to use MIGS in two key settings. The first is in conjunction with cataract surgery. So for people who have glaucoma, particularly where it's mild or moderate, and they're using glaucoma eye drops, and they develop a cataract, which most of us will as we age, and need cataract surgery to improve their vision, then I will use a MIGS procedure at the time of their cataract surgery to help give them better control of their pressure and reduce or hopefully eliminate their need for glaucoma eye drops, depending on the severity of their glaucoma. And procedures I commonly perform would be the eye track, which is the catheter system, or a stent, a small metal stent made of special surgical grade material to help keep the drainage channel open. And then the second category is for people where drops are not working. So people are on often multiple, often say 3 glaucoma medications, but yet their pressures are still not adequately controlled, or there's signs that their glaucoma may be getting worse. And so in that setting, we can do a MIGS procedure to create a new channel to help again control their glaucoma, help preserve their eyesight, but without the need for going to that major invasive operation. And so for people in that setting, I would talk to them about a procedure such as the Zen, which is a small stent, which again helps the fluid drain out, or the PreserFlow, which is a slightly larger procedure. But both work in similar ways to help control eye pressure in a much less invasive operation with a more predictable lowering of their pressure, with a faster post-operative recovery and a better safety profile. And it still leaves us options up our sleeve if we need. You can still have the more invasive procedure in the future if you were ever to require it. So it doesn't remove or eliminate options, but for many people it can help us avoid the need for that major invasive surgery, which and they're often really pleased to find out that that's an option for them.
I think they would be really pleased, Dr. Kerr, because I think if it was me and I have a surgery, which is, you know, a serious surgery, you've obviously got cutting in surgery, you've then got potential for infection, you've then got a long recovery time. You know, it's necessary on occasion, but you certainly would want to avoid that. So when you're using that word, you know, non-invasive, that's exactly it. The fact that you can come in and you can have a low rate of infection, complications, quick recovery. I mean, that is such a good news story for our patients. One of the questions that's come in on the chat is that, do you still have to have any lifestyle changes after the MIGS surgery though? You know, it sounds very quick and you're back to life. What sort of changes might be still necessary?
Yes, yeah, no, excellent question. So I think we always want to be holistic in our management of glaucoma. And so undeniably, lowering eye pressure is one of the most important things we can do to help treat glaucoma. And so the stent or the catheter procedure will help us do that. But I think it's still important to address other factors which could be contributing or exacerbating people's glaucoma. And there are different things that we know that can affect our eye pressure. Certain things such as simple as caffeine can increase our eye pressure. Fortunately, though, things like coffee or tea, it only increases the eye pressure a small amount, and fortunately for a small period of time. We know that general cardiovascular exercise is beneficial for glaucoma, so walking and those type of activities. We have to be careful with resistance training, so resistance or weight training. And if we do those procedures, we need to be careful not to hold our breath during them. And after any surgical procedure, it's always wise to avoid those type of activities, certainly in the first week or two after the surgery. But if you look at the minimally invasive ones, we're talking avoiding those procedures for a week or two versus the conventional surgery, where sometimes you can't even be doing those procedures for 4 to 6 weeks after the operation. So it is a much shorter recovery than a conventional procedure.
So you'll find, you know, things like scuba diving and bungee jumping are always going to be not highly desirable when you have glaucoma, but definitely you're going to have to be aware of those around the time of surgery. We've got a question come in from Leanne. She says her son has congenital open angle glaucoma, and can MIGS be performed on him?
Yeah, good question. So it can, and it's particularly that canaloplasty procedure, the catheter one that we talk about, the eye track, which is actually a very versatile procedure, and it can be used in adults, but it can also be used to treat children. And as I say, even young patients with congenital glaucoma can have that procedure to help treat them. So it's very versatile, that we can use it from the youngest patients through to adult age patients as well. Obviously, it depends again on his severity, and so I always encourage that he gets an appropriately qualified ophthalmologist's opinion. But absolutely, there are MIGS procedures that can be used in children. Now, an increasing number of papers coming out showing the effect of, or the benefit of canaloplasty, or that catheter procedure in congenital glaucoma.
Just that word, canaloplasty, is that right?
Yes, you said it beautifully. Perfect.
Canaloplasty. Right. So there you go. Definitely ask your doctor about that, Leanne. Another question come in from Dawn. I have normal tension glaucoma, have had, oh gosh, I've got to sit back because of my eyes, which is not from glaucoma, trabeculectomy in both eyes and a redo. The doctor is talking about more surgery and presumes a stent. Is it risky in that kind of situation that you've had a trabeculectomy before in both eyes, and now, you know, should you have more surgery?
Good question. So I think there's a few interesting points. That first of all, that even for people with normal tension glaucoma, so that's where their pressures are in the normal range, can still benefit from eye pressure lowering. And we can, where drops are not working, do trabeculectomy in people with normal tension. And we think that it helps alleviate the pressure for day to day. So even if the pressure number seems low to start, surgery can help control or provide a more consistent pressure to reduce those fluctuations. But as Dawn has, and is not alone, that about 50% of trabeculectomy operations, the body naturally wants to heal, and it will close over that channel and scar so that it doesn't drain. It sounds like that might have happened, and that's why she's had the redo surgery. And in people where the trabeculectomy has failed, we have a number of options. You could repeat the trabeculectomy, but again, if the first one failed, then often the other one, you know, Dawn's eyes clearly healed very well. And so people will try to use a type of or actually a tube that helps keep that channel open so the body cannot scar down, and it keeps the channel open. So it's actually probably a tube operation, which is actually a slightly larger stent than the minimally invasive ones. The minimally invasive are probably not better for the setting of where you've had multiple surgeries where the body has scarred down. We did actually, interestingly, though, publish a paper in that very setting where we actually used MIGS procedures in people who had failed trabeculectomy. We published that about 5 years ago, about 3-4 years ago now. And we did actually find that for a proportion of patients, we control their pressure well enough that they didn't need that big tube operation. So about 80% of people did avoid. But that is obviously, as this is, you know, in specialist hands, where this is not the usual setting for where we do MIGS, but you can, and surgeons do use MIGS where we feel that it would offer you benefits over doing that major invasive surgery. But certainly a very complex case there with Dawn's eyes.
Yeah, absolutely. Don't worry, Dawn, your eyes are precious, and they're going to be considering all these factors. And I'm loving the way that you are responding, Dr. Kerr, with statistics, you know, with all of these decisions, which are, you know, someone's precious eyes, right? And so there's so much anxiety, and understandably so. There are massive decisions to be making. And I love the way, as a clinician, you're actually going, well, you're looking for research. You're looking back on what the statistics say for different people's situations, you know, and currency of that data, which is strongly influencing the choices that you will give to your patients. I've got a question here from Gayla, who says, is there a big difference between Zen gel stent and the PreserFlow? Are they very different?
Good question. So there are a number of differences between the Zen and the PreserFlow. So the Zen is smaller, so it's a smaller stent. It's normally placed from inside the eye, just through a single keyhole incision. So the Zen has certainly less initial incisions, and we feel that again helps have a comfortable eye after the procedure, less change in your vision because of changes in the shape of the eye, and again a shorter operation, and it avoids us to have to do any stitching on the eye, and so there's no risk of a stitch becoming loose or infected. The PreserFlow is a slightly larger stent, and it's placed from, we open up the skin of the eye, and then we place the stent in, and then we close the skin of the eye over the top. It is a slightly larger diameter, so we think it's less prone to blockage. It does take a little more work surgically, but it does give us certainty that we've placed the stent where we want it to do, and enables us to use slightly stronger anti-scarring medication. But they do work in similar ways. They are designed to treat similar indications, and again, evidence will help guide us here. And so I agree, patients want to know, well, what are the chances that this will work in my eyes? And so obviously I do a lot of clinical trial research, but I also am involved in a collaboration, the International Glaucoma Surgery Registry, which collects real-world data, hopefully to answer us these very types of questions about how well do these different procedures work in people's eyes.
Fantastic. I hope that was very, very helpful for you, Gayla. And we have a question come in from Deborah. Do you still use Fluoro 5 injections? Post-trabeculectomy, had great success with these. So
right, yeah, great. Fantastic. I'm really happy to hear that Deborah's had great success with those. And so for people who are not familiar, those are injections of an anti-scarring medication that we give after surgery. And so with our conventional surgery, we make a small channel to let the fluid drain out. But as we mentioned, the body wants to heal and scar that channel down. And so the 5-FU medication is a medication that inhibits the body's ability to scar. So it's trying to keep that channel open. And absolutely, I do that procedure after trabeculectomy to make sure that it continues to work. But it's I do it because it helps but it's always nice when you don't need to do any kind of sort of intervention or injections after a procedure. And so the nice thing about the MIGS procedures like the Zen or the Presiflow is that you very rarely would need, if hardly at all, need to do the 5-FU injections afterwards. So those procedures, they're made of materials which are very inert, and so that the body is less likely to scar down around them. So absolutely needed frequently after TRAB, but needed much less commonly after MIGS procedures. And Deborah's a brave patient. Some of my patients are less keen to have an injection in their eyes afterwards. So we do it, it's painless, but the thought of that is not always something people look forward to. So if we don't need to do it, then they're often very happy. Yeah.
Well, you get the Bravery Award, Deborah. Well done. Thank you so much. And this one hasn't come through the chat, but I've just thought of it, so I'll ask it for you. I'm assuming, therefore, that there must be a lot of collaborative relationships between, you're talking about scarring and wound healing. And so here you are sort of doing the surgery on the eye, but there's obviously these other areas of medicine, which there's a crossover there on anti-scarring medication and the influence on how your patient recovers. Is that an area that you just now sort of have some cross collaborations into the research that you're pioneering and the way you also work as a physician?
Yeah, no, it's good, absolutely. So we're really fortunate at the Centre for Eye Research Australia that we have really talented glaucoma surgeons and researchers. And so we have a team that is dedicated to looking at wound healing and how that influences the outcomes of our surgery. We also have a team that looks at the mechanics of designing these new types of stents, looking at the fluidics and how they do. So then we have others looking at work such as stem cells and gene therapy. So at CERA, we have so many different research groups which are all approaching this from different angles, but they will all ultimately probably end up working together to help us achieve our ultimate goal of helping to preserve people's eyesight from glaucoma and help improve their quality of life.
Fantastic. Another question come in through the chat says that if one type of MIGS doesn't work and you need another type of MIGS, would you remove the first one to put the second one in, or do you actually leave it? Which is kind of interesting for me as, just objectively going, would removing it create more potential damage and scarring, or or do they not go together? So great question.
Yes. No, I like the way the person thinks. So often we don't need to. So if you do have a MIGS procedure, and if it's not giving the reduction in pressure or medications that we need, we often just leave it there. You're quite right. Trying to remove it would actually likely cause more problems or incite some trauma to the eye. And so, yes, so if one's there, it's not going to cause any problems. You don't see or feel it, but then we can still look at a different procedure. And often they will work together in different ways. And so, for example, if somebody's had a stent, but that hasn't controlled it well enough, then I could do the canaloplasty or that eye track procedure to help clear more of the drain, so treat more degrees of the drainage channel. And so it works sort of synergistically with the stent. And then for those ones that don't work for the natural drain, then they can still have a procedure which makes the new drainage channel. So people will often have multiple types of MIGS procedures in their eye, but they all happily coexist. They're all very, very small. So they're not taking up a lot of space, and they all happily coexist. And so it's very rare that that you would need to ever remove a MIGS stent. They're very safe. They usually stay. There are occasional circumstances if it becomes exposed, then you might want to take it out. But that is fortunately very, very rare, and usually they're just left in place without any problem.
Absolutely fascinating. And that makes sense. Why touch what's not broken, officially broken? Might not be not giving you the results, but it doesn't mean that it actually needs that extra step. Fantastic to know. I might then finish with a question that says, well, is there a future then that you might put in a couple of stents at the same time for those intentionally for that same sort of effect?
Right. Yeah. You're a trendsetter. So there is definitely talk about that, and there are some studies going on at the moment to look at that. In clinical practice at the moment, we often will do a single procedure, but I must admit that for a number of patients, particularly where we're really motivated to help be drop-free and give them the absolute greatest pressure reduction we can with the MIGS procedure, I will combine a catheter procedure. So I do the eye track, which helps dilate and clear out the drainage channel, and then once it's dilated and cleared out, then I will put a stent into the canal, into that channel. And actually it's easier to insert it too once it's already been dilated and cleared out. And so that's a common procedure which I perform, where I do two procedures, the eye track plus then either an eye stent or a hydrus working together. And as I say, I've been doing that now for probably 12, 18 months, and I've been very pleased with the results in terms of the pressure reductions, and patients have been really happy with the results as well.
Do you always do the operation on both eyes at the same time, or would you do one and then the other, or sometimes it's only required in one?
Good question. So for laser, I often, the SLT will perform both eyes at the same visit. And that means less visits for the patient. It also has some cost savings for the patient because they only have to pay 50% for the second eye if it's done at the same time. But for surgery, as a general rule, we always treat one eye at a time.
Very interesting. And finally, I know I said the last one was a final, but I just love it when questions come in through the chat. We often get patient questions that says, well, something's available overseas. And, and you as a glaucoma specialist, you've trained overseas. You can see things that are pioneering and coming into that space. And when you're that patient, you think, well, why isn't it in Australia yet? How does that happen? Why wouldn't Australia sort of automatically have the very best of everything? Is it true, or is it not true that sometimes you can get better treatments overseas?
Yeah, no, it's a good question. Well, actually, it's actually probably the opposite, that we are really lucky here in Australia that we have access to more of these minimally invasive procedures than they do in the US, more than they do in Canada, more than they do in many other countries. And there's a number of reasons for that. And one is actually, people don't often know, but we have a really successful medical industry. And there's a company called Nova Eye Medical, and they're actually based here in Adelaide. And so they're a company that initially made a number of glaucoma products, including laser, in fact, the most commonly used laser in the world. And now they've split off, and now they've got this group Nova, which specialize in making glaucoma surgical procedures. And so they're based right here in our backyard. And we're really lucky that we actually get access to these procedures like the eye track before many other countries in the world. And that's really exciting. So in fact, other countries often look to us as Australian surgeons to see what we're doing and what procedures we're using. And so that's a pretty exciting homegrown story, that this procedure that we're doing is often, first in the world, has been done very first time here in Australia with an Australian company. And in fact, parts of the devices are made in a centre in Dunedin. And so it's really a sort of South Pacific Australasian enterprise. And so patients in Australia should feel really fortunate that it's actually a really good time, and they've got a great place to be, that they have access to all of the very latest treatments that actually many of their friends overseas may not have access to.
Well, there you are, folks. You've heard it from the expert who is, pioneering in this space. And it's really great to hear, isn't it? How blessed are we? And I know that many people come onto our Facebook Lives who are from overseas as well. And we also feel your pain and frustration at times when things aren't available in a lot of places around the world. So we are truly blessed. I think it's great that our patients are always looking globally and actually doing their own research and hearing about things in the wind. And so definitely ask your doctor, ask your specialist, what is available for you. Also to appreciate that, you're hearing Dr. Kerr's been doing things just in the last 18 months. This area of glaucoma, technology devices that are coming in the market is changing rapidly. And so that's a good news story for all of you. Never be afraid to go back. And even if you heard something 5 years ago wasn't possible, definitely just keep on asking. And thank you so much. Our time has flown. We've spent 40 minutes having a chat conversation. Thank you to all of the listeners who have popped things in the chat for us to ask Dr. Kerr. I will look forward to having you on another Facebook Live in the future.
Thank you, Annie. Thank you so much, and a pleasure talking to you. And thank you, everyone, for joining us this evening.
Everybody, it is Glaucoma Week, so make sure if you haven't already signed up for the 7 Sites Challenge. We are doing that across Australia, and you can do that anywhere in the world for Glaucoma Week. In fact, for all of the month of March, you can go to 7sites.org.au. You sign up for free. You either do it individually, or let's make it more fun. Get a team together, get your whole workplace together. You sign up, and basically what you do is you think, I'm going to go out and explore and get different. I'm going to see sites. I'm going to value my site. I'm going to get other people to appreciate what we sometimes take for granted. So there'll be different themes of things that you want to go and see, you want to take a photo of, you want to upload it onto the website. Also encourage others to support you with a bit of fundraising. We're talking maybe $20, $50 here or there to support the services that Glaucoma Australia gives. We currently are supporting about 30,000 people with improving their education and support through our educators and also supporting research, which is happening across the country. So get on board with the 7 Sites Challenge. It is definitely not too late. It's actually perfect time to get yourselves involved. I look forward to seeing the photos that you're going to put up on the Facebook feed, and you can come and have a little giggle at the ones I post as well. So thank you so much once again, Dr. Kerr. Thank you for everybody who has tuned in for this Facebook Live, and thank you so much for making this such a fun and engaging conversation.
Thank you.